Today we're going to be looking at mechanisms of change in ACT therapy. So to begin, I thought it would be helpful to introduce ACT therapy. So ACT actually stems from cognitive behavioral therapy, which is the most empirically supported and widely used therapeutic modality. Cognitive behavioral therapies try to target reappraisal and cognitive behavioral change, which is like lessening the emotional impact of stressful situations by reframing the initial perceptions of it. And this has been linked to treatment outcomes such as drops in depressive and anxiety symptoms. In contrast, third wave cognitive behavioral therapies such as ACT have begun to incorporate concepts such as mindfulness, values, and intention. And ACT aims to increase psychological flexibility in order to adapt to internal and external environments. Internal and external environments and take action in accordance with values regardless of context. And this is different than trying to change your thoughts. And this is linked to treatment outcomes like drops from depression and anxious symptoms. So to kind of dive deeper into what psychological flexibility actually is, it's conceptualized within what they call the hexaflex model. So it's comprised of 6 dimensions of psychological flexibility, as well as 6 dimensions of psychological inflexibility, which I'll talk about next. So to begin, psychological inflexibility has 6 dimensions: present moment awareness, which is attentive, being attentive and aware of your feelings from moment to moment; contact with values, which is prioritizing what's truly important to you on a daily basis; committed action, which is taking steps towards what's important to you despite the setbacks; self as context is keeping a broader perspective in the face of difficult situations; diffusion is allowing difficult feelings to flow through you without clinging to them; acceptance is making space for difficult thoughts and feelings and allowing oneself to experience them. And like I said, correspondingly, the 6 dimensions of psychological inflexibility consist of intention unawareness, which is doing things mindlessly, like on autopilot; lack of contact with values, losing touch with what's truly important to oneself; inaction is being derailed or overwhelmed by negative feelings; self as content can be thought of as criticizing or shaming oneself for having negative emotions; fusion is getting trapped in unwanted thoughts and feelings; and experiential avoidance is distracting oneself from experiencing negative emotions. So ACT has been shown to address a wide range of physical and mental issues. ACT therapy has been linked to physical benefits, such as smoking cessation and weight loss, as well as improving ongoing conditions such as managing chronic pain, cancer, and fibromyalgia. The largest body of work on ACT has actually examined its benefits for psychological disorders. ACT has been useful in treating depressive symptoms, anxiety symptoms, and stress. So one of the reasons we think that there are such robust treatment effects in ACT is because there are certain treatment mechanisms or processes helping to explain these drops in distress. So given the central nature of the hexaflex model within the practice of ACT, studies have begun examining possible mechanisms of action to explain treatment gains. So actually 32 studies, as of my knowledge, have demonstrated that changes in global inflexibility has been linked to drops in psychological distress. By psychological distress, I mean drops in depressive symptoms, anxious symptoms, life stress, and work stress. Within these studies, despite the conceptual precision of the hexaflex model, the majority of these studies have used the AAQ to measure psychological flexibility. The AAQ and its revised version, AAQ2, is the most widely used adopted measure. And but in recent studies, it's been found that it's actually just measuring global inflexibility and doesn't assess or measure all of the dimensions of the hexaflex model. And since then, a few scales have actually tried to assess different individual dimensions of the hexaflex model as well, such as the mindful attention and awareness scale which measures lack of present moment awareness or inattention. An example item is it seems I'm running on automatic without much awareness of what I'm doing. And the 5 facets mindfulness questionnaire, specifically the non-judging subscale, is a measurement of self-less content, which is an example item is I correct myself when I think the way I shouldn't. So these scales have not comprehensively measured all 12 dimensions succinctly, which is one of the main goals of the current study. So the current study examined all 12 dimensions of psychological flexibility, and we did this by tracking progress with the MindFlex assessment system, which is an online assessment. It obviously assesses all 12 dimensions, as well as outcome measures like depressive and anxious symptoms and well-being and need satisfaction. And this online assessment takes about 15 minutes for the clients to complete, and it's done ideally at the baseline of treatment or before treatment begins, and then 2 months post-treatment. And then once the client completes the assessment, standardized profiles are completed or created by myself or Ron. This is an example of a profile. So just to orient you, if you look at the flexibility, you can see 6 dimensions of flexibility as well as 6 dimensions of inflexibility. There's also a global flexibility composite and a global inflexibility composite, and well-being outcomes like sense of autonomy, life satisfaction, and distress outcomes like depressive and anxious symptoms. And it's tracked over 2 months of treatment most times, but the therapist has, they can give the assessment to the client whenever they see fit. So to go into the methods, so the steps of the MindFlex assessment, so first therapists are enrolled. They complete background information like how long they've been seeing clients, what their training entails. If they seem like a legitimate therapist who has a fair amount of training, then we give them a link where they can enroll clients. So then they complete the therapist client enrollment form, giving background on the client, what their presenting problems were, questions about the rapport between the patient and the client. And then from there, the client's invited to complete the client baseline, which is the MPFI. So all 12 dimensions of psychological flexibility are assessed, as well as depression, anxiety, and well-being. And then client follow-up, which is the same assessment completed 2 months later. And we also collected data from a therapist follow-up form, which shares the therapist's perspective of how the client improved or didn't improve over the course of treatment. So to go deeper into what the therapists look like, we had 19 therapists in our study, all recruited from the Association for Contextual Behavioral Science website. They're mostly white, mostly female, an average of 13 years seeing clients. The majority did individual therapy, but also 44% did group therapy. And then for the clients, at baseline, we had 91 clients. They're mostly white and female as well. The average age was around 36. The mean sessions completed, or the amount of mean sessions completed at baseline was 13, but the median was 2. That's because there's like this group of clients that completed the baseline actually like a couple years into therapy, so that shifted the mean, but the median was 2. And then according to the therapist, the presenting symptoms was 48% had a diagnosed anxiety disorder, 36% had a diagnosed depressive disorder, and 20% came in with work stress-related issues. And at follow-up, we had 57 clients, and there were no demographic-based differences between those who completed the follow-up and those who did not. And demographics such as gender, age, and then levels of flexibility, inflexibility, and depressive symptoms. And this was all conducted through mindflex.org. So for the measures used, we used the multidimensional psychological flexibility inventory, the MPFI, to measure flexibility. So this captures 6 dimensions of flexibility and a composite score of global flexibility. So for an example item, this is for the dimension of diffusion. I was able to let feelings come and go without getting caught up in them. And then there are 6 dimensions of inflexibility, as well as the composite inflexibility score. And the sample item for inattention and awareness was I did most things mindlessly without paying much attention. And outcome measures, depressive symptoms was measured by the patient health questionnaire. And the sample item is how often have you been bothered by little pleasure or interest in doing things, feeling tired or having little energy, and poor appetite or overeating. So to give you an idea of what we tested the mediation model. So we're looking to see if ACT led to drops in depressive symptoms. Given that this is a single arm design, it wasn't a true mediation model, but that was path C. And then path A, we looked to see if there are drops in inflexibility and gains in flexibility over the course of 2 months, and if these if the residualized change score of changes in flexibility and inflexibility were correlated to residualized change in depressive symptoms. So the results for path C, we ran repeated measures, and we found that there were significant drops in depressive symptoms with a Cohen Z of -0.22, and this remained significant with intent to treat analyses. For path A, investigating the changes in flexibility and inflexibility dimensions, we ran repeated measures in NOVAs, and we found that there were significant drops in the global composite score of inflexibility, as well as specific dimensions such as experiential avoidance, inattention and awareness, fusion, and lack of contact with values. And there are also significant gains in the global flexibility composite score, as well as specific dimensions of acceptance diffusion. And all these results were significant within our intent to treat analyses. And then finally, path B looked at residualized change in processes correlated with drops in depressive symptoms. So for this, global flexibility, actually all 12 dimensions of flexibility and inflexibility were found to be significant, but I put the most robust findings here. So global flexibility was correlated 0.74. Fusion and lack of contact with values was also strongly associated, and global flexibility, as well as specific dimensions, acceptance and diffusion, were robustly linked to drops in depression. So in conclusion, the study tried to elucidate mechanisms of change in ACT therapy. We saw drops in depressive symptoms over 2 months, as well as drops in psychological inflexibility and increases in psychological flexibility. And residualized change in processes correlated with drops in depressive symptoms, and global flexibility, acceptance, diffusion, as well as global inflexibility, fusion, and contact with values most robustly. So some clinical implications for the study. So this supports ACT-based interventions, showing that psychological flexibility may be a mechanism of action for treatment outcomes. Also, some clinical utility of the MPFI was proven. So when you take this at baseline, it can demonstrate to the therapist the strengths and weaknesses of the client. Maybe they're super low in acceptance when they first come to therapy, and maybe that's a target that you can choose to increase over the course of treatment. So this allows also to therapists to see how clients are responding to their treatment, or whether they're not, or if they're not. Some limitations: there's a smaller sample size, only 57 clients completed the follow-up. So future studies, and although all of the intent to treat analyses remain significant, future studies can still seek to find a larger sample size. There's variance in ACT training. Therapists reported different levels of ACT training. Some were trained by workbooks or online programs. Some were actually supervised by ACT trainers, so we had some variance there. So the baseline was completed at different stages of treatment, which I kind of said earlier. The mean obviously was different than the median of sessions completed before they took the baseline assessment. And this could be our results could actually be stronger if we got everyone to complete the baseline assessment before treatment, because it's shown that treatment effects within the first 8 weeks of treatment show bigger changes in depressive symptoms. So we might be missing some stronger effects potentially. We only assessed at 2 time points, so there's only 2 waves of assessment. Future studies could do multi-wave assessment, which would allow for more fine-grained analyses to clarify the directionality nature of these processes. Because right now it's purely correlational, so we don't know the direction of association. And finally, this is a transdiagnostic approach. We didn't run analyses separate within those who were displaying anxious symptoms as versus those who are displaying depressive symptoms. We just ran analyses in the complete population. So I just wanted to thank my advisors, Dr. Ron Raghi, and also Jen Dax for their continuous support and guidance over these last few years. This project wouldn't have been possible without them. And I also want to thank my family and friends, many of which are actually on this call right now. So thank you guys for your support.